So I know that the panel doesn't have any questions, but I do. So I just thought we'd have a brief discussion. We don't have a full roundtable, but there are just a couple of points I thought that would bear discussion here. So one of the things we heard about through patient conversation and actually in some of the discussion here is that the measures in current clinical trials don't completely reflect the patient experience. So my question to you folks is, are you aware of any efforts to try to improve that? Are there other measures that could be included in trial design on a relatively cost-effective basis that could help inform the patient experience a little bit better and the effective treatment on it? We did hear during the modeling discussion that there are some relatively straightforward instruments in terms of quality of life and utility that seem to be largely absent from these trials. But even beyond that, are there other measures, patient-centric measures, that should be under consideration that up to now have not been? And certainly Dr. Kimball and Leah, feel free to chime in as well.
But it was developed as a clinical practice tool, not a trial design tool. And as such, in the U.S., has not really met the FDA requirements for being an accepted patient outcome. That's in contrast, actually, to Europe, where it is widely accepted and actually is part of their guidelines. It's a criteria for treatment and other things. In response to that, over time, we've started to see the development of different PRAs that are validated. Amgen has one, and a number of other companies that has allowed at least improvement for signs and symptoms to get into the label in a more patient-oriented way. I think the problem as a field we face is everyone is developing a different one, and so we're not going to be able to compare. Of course, they're all the same at the end of the day because they're asking the patients their experience, and they get pretty much the same answer, but they're all enough different that it's going to be very hard. So in some ways, we just need to converge to a single one. I would push back a little on sort of DLQI versus PASI. So what's interesting about that is that for an individual patient, their DLQI might not match their PASI as tightly as you would expect. And clinically, we see this. We see patients who have incredible coping or denial mechanisms around their very severe disease. We also see patients who have very small bits of disease who are incredibly distressed by every spot. But when you take the population in aggregate and move it, and you have a highly effective therapy, you absolutely see tight correlation in DLQI reduction that correlates to the improvement. So it's really for an individual patient, they may not correlate precisely, but for a population seeing improvement, they definitely do.
Okay.
I just had a
go ahead.
Quick, I guess, quality of life question too. Most of these medications are infused or injected subcutaneously, whereas Firmalast is an oral medication. I just was wondering about comments, concerns for patients either not taking their pills, because we all know that not everyone takes all their pills every day, versus having to go and get a shot on a weekly or monthly basis.
So patients do these themselves. So other than the first teaching for the subcutaneous injections, I would say all of my patients, except for one elderly one, who really prefers to come in and he's on a quarterly regimen, and that makes sense. They're injectable pens like an EpiPen, and I have had fewer than 5 patients ever decide to go off an injectable because of the injections. Now, and some of them are 3 or 4 times a year or every month, and that becomes very manageable. That said, patients in general prefer the concept of pills, especially if they're new to the concept of systemic therapy. And so once they've kind of made that, it's not such an issue, but for patients for the first time, pills do seem to be a preference.
One of the compounding factors Steve Feldman brought up is that the number of the top 3 issues for treatment failure for all these is compliance followed by compliance followed by compliance. You actually put a computer chip on the lid that you dispose your needles in and found that people do not take their medicines in a consistent fashion, whether it's pills or injectables. So again, it makes it really difficult because there's a really high variation, much higher than you can imagine. So the answer is people don't like shots, and a lot of times they'll take them until they're clear and then wait till it starts coming back and re-inject. Same thing's true with the pills, but patients are patients.
So we didn't actually circle back, I guess, to you, Brad, around the idea of including additional measures in trials.
Sure. So seen over the years is that you have had an evolution of measures and trials. As you look across the 38 or so clinical trials that we included in your report, the early ones that were predominantly etanercept and infliximab maybe didn't have the breadth of instruments in them, whereas more recently you probably do. So generally you would see a symptom measure in some of these trials. A number of labels now have patient symptom reported outcomes included in them. Generally, what I've seen recent studies have DLQI. As Alexis stated, DLQI has some limitations, but is one of the better impact measures that you can see for patients. Occasionally, you see a productivity measure, but because of the design, because of the way the clinical trial is moving forward, and what's required by the FDA or not, or accepted by the FDA or not, as far as these measures, you see a lot of variability. I think many of the tools that we need to do that measurement are available. It's just that we haven't necessarily seen them over the 20 years or so of the trials.
I just want to add that we talked about this in the 2016 review, that in March 2016, the FDA held a patient-focused drug development meeting on psoriasis. And about half of that conversation, the first half of the day was spent discussing symptoms, and then the second half was discussing treatments. And we spent a lot of time getting at things like itch and patient challenges that are reflected in clinical trials. So there was a very poignant part of that meeting where the FDA asked the 100 or so patients in the room, "Are you itching right now?" And patients voted, via handheld responders. So I think that was something the FDA heard certainly very loud and clear from the patient population, that they'd like to see these things reflected in trials.
Sure. So I know we have a few minutes before we need to transition to voting. So Dr. Feldman, you mentioned the compliance issue and how compliance with one drug begets compliance issues with another. One of the issues we highlighted in our 2016 review, and again in our update, wasn't really part of the discussion this morning, but most of the clinical trial evidence we had available to us was based on patients who were naive to one of these agents. So a very relatively small minority of patients had tried one of them prior. And by definition, because there are so many agents available in this country, most of those trial patients were not in this country. So what can you think about moving forward to try to inform later line use, sequential use? Because one of the key uncertainties here is when each of these should be used in the sequence of treatments.
I'd be curious if Dr. Kimball thinks as a clinician. Yeah, we have the same problem that there's a lot of art still in psoriasis, and there's not as much science. I wish somebody would walk in and they could look at their clinical pattern and say, you're a 17A or you're a 10 alpha or XYZ. Option. And we don't have that yet. When somebody comes in, we use this general data and kind of apply to everybody. Our experience has been. And again, that's where the science needs to go. We need to find those additional markers so that we know when somebody fails one, what is the likelihood of them being successful with the second line therapy. And I have not seen that data yet, or aware of it.
So, generally speaking, patients who have failed a biologic are more likely to have lower success rates. That's pretty clear from the trial data. But irrational of what you go from one failure to the next, to your point, is not been established. That said, I think what is missing from any report would be the conversation that you have with the patients and the nuances of their comorbidities and issues that make you choose the first drug to begin with. And that goes back to that, how do I pick among these 12 with a patient in front of me? So I'd say the two biggest factors are presence or absence of psoriatic arthritis. Some of these drugs are better or worse than arthritis, so that's going to play a role. The second is body weight, because again, if I think I'm going to be in a dose escalation scenario because of weight, and some are more or less sensitive to weight issues, that may change what I get. Sure. Then you go into the third sort of set of criteria, which is, does the patient have a risk factor or comorbidity that would benefit for them? Do they have Crohn's disease, CHF, history in the family of multiple sclerosis, fear of needles, want to get pregnant, and that's all in the mix. And then finally, I pick my 3 or so choices, and I send it to the pharmacy tech and say, what can I get approved? And what's the copay for the patient? Literally, that's kind of where we are today. And so that informs then what that second choice is going to be, because if they have that family history of Crohn's that's strong, I may be going with the IL, 12, 23 inhibitor or 23. And so that's why that data may be hard to get. It's very nuanced to this disease.
Sure.
And
recognizing that some of this is confounded by insurance design, we'll have some time at the end after the votes to have some reflection on that. I hope you guys will stay because I may throw some questions out to you even if you're in the audience. So great. So thank you very much for your input. I'll invite Reiner and Dave up to the table. Felicio, I don't know if you want to come up as well. That's fine. And I'm going to stand back here while you take them through the voting, right?
Sure. So we're going to start the voting.
Voting training.
Everyone on the CEPAC should get logged in to the Wi-Fi network. If you're having issues logging into the voting software, just raise your hand and we'll have people coming around to help you. Of course, as usual, we're going to run a test question so that everyone can make sure to practice once before we get started.
I knew the answer to this one already.
What?
I knew the...
Do you? Maybe once everyone gets logged in, would you put your name placard facing upwards? Just turn it so that we know that you're all logged in and ready.
We should be seeing vote polling closed, correct? Okay.
All right, it looks like we have everyone logged in. We'll go to the first question, which is numbered 0. How many stories is the tallest building in Vermont?
This was actually the answer was on the Vermont NPR on the way up. I was listening to it. So.
It's also on vermonttrivia.com. Yep. Laura will come over to you. All right, it looks like we have 11 votes. And the correct answer is, wow, C. Everyone, we have 82% answered correctly. Everyone must listen to NPR. All right, Dan, it's all yours.
Azealia, just confirming, you did get the right number of votes, though, too, right? Because that didn't reflect how many people voted.
We had 11 responses, which is 11 CEPAC members. Yep, correct.
Okay. Thank you, Celia.
You can use this if
I
you
can
want.
use that. Good. Okay.
If you want to get started. I'm just going to change it from percent to absolute numbers.
Okay. So just to, as we're going through the votes, the consideration here is what patient population we're talking about. So these are patients with moderate to severe plaque psoriasis for whom treatment with topical therapies, older systemic therapies, and/or phototherapy has been ineffective, contraindicated, or not tolerated. So they've had to move into candidacy for one of these targeted immune modulators. And while Celia does her work here, are you done?
No, I'm going to have to take it out of the slide presentation so people can start discussing, and I'll fix it as the discussion happens.
Okay. So our focus, as we mentioned at the outset, will be on the 4 new therapies, the 3 IL-23 inhibitors, as well as certolizumab. And I believe the first question is on certolizumab. So one of the questions that Rob raised earlier was around how to consider, so not necessarily so relevant for certolizumab, but for the IL-23s in comparison to the subcutaneous TNF inhibitors, those being adalimumab or etanercept and certolizumab, because there were some differences noted in at least some of the effectiveness measures, to try to think about how that comparison to the TNF inhibitors as a group should play out. So one aspect you should be thinking about is whether there is the availability of direct head-to-head evidence between the IL-23 in question and one of the TNF inhibitors, one or more of the TNF inhibitors, and whether the comparison between TNF inhibitors helps inform your thinking. So by that I mean if you see greater effectiveness with a drug versus a TNF inhibitor it's been directly compared to, and then that TNF inhibitor in turn has greater effectiveness than one or more of the other TNF inhibitors, it may be easier for you to think about that more as a group. So that's a possibility. Are we set now?
We are all set.
Okay. Another thing that maybe Reiner and Felucio can weigh in on is, in terms of the TNF inhibitor comparisons, how consistent were those differences, whether we're talking about PASI 75 or some of the other outcome measures. I actually need to be reminded how many network meta-analyses we did. Was it just PASI 75? Did we also look at PASI 50 or 90?
We did look at PASI.
I mean, you got to have your mic on.
We looked at PASI 50, 90, 75, and 90 in the
Okay.
meta-analysis.
Okay. And results were similar?
Yes.
Okay. So then the league table you have in your evidence package is on PASI 75, shows statistical differences for adalimumab in comparison to etanercept and for certolizumab in comparison to etanercept, and no difference between adalimumab and certolizumab. So that's just something to keep in mind. Okay. So we're starting with certolizumab. Oh. What was that? Yeah.
It seemed like there was no line between adalimumab and etanercept. So I think
Correct. Those are based, well, but the statistical differences in that league table were based on the indirect comparison of adalimumab and etanercept based on the placebo-controlled evidence, essentially. Right. No head-to-heads between the TNFs, right? Wait a minute, that's not true, actually. Certolizumab was compared head-to-head to etanercept. Okay.
But there's no line in the schematic.
Between certolizumab and etanercept?
Yes, it's not etanercept.
Correct.
That is correct.
Correct. Okay. Maybe people could put their 10 cards back down so that then when you have a question, you can raise it and we'll know who's asking the question.
And just make sure to speak into the mic when you make comments so that people on the webcast can hear.
Okay. All right. So I can try to drive this and you can step in if I fail. Okay. All right. So one thing to just remind you of is let's see if we can have some discussion, review of the evidence before people put their votes in, just so that you hear kind of the breadth of the discussion first. So this first question is the evidence adequate to demonstrate that the net benefit of certolizumab pegol is superior to that provided by the other subcutaneous TNF inhibitors, adalimumab and etanercept? And Reiner and Felicia, why don't you remind us of, you already basically said it, but remind us of what the evidence says for those comparisons.
So we have one head-to-head trial between certolizumab and etanercept. And in the direct evidence, in the network meta-analysis, we have that certolizumab was significantly better than etanercept. We do not have data on other outcomes, which includes the IGA, the PGA, and the DLQI. And on adalimumab, all we have is indirect comparison between certolizumab and adalimumab, which was not significantly different.
And in that head-to-head study, there was also a statistically significant difference at the higher dose of certolizumab, but not at the lower dose, right?
That is correct.
Dr. Kimball, do you have a sense of how the dosing will play out in clinical practice for certolizumab?
So in general, we have not seen to date that increasing the dose, with the exception probably of infliximab, makes any real safety difference. Although again, I think most people try to keep at the lower dose where they can. In this environment with so many highly effective drugs, though, I think clinicians are going to try to optimize efficacy where they can as well. So I do think you'll see both of them used in that scenario, and but for it to be competitive, it's going to need to be used probably at the higher dose. That will come with a higher cost.
Okay. Great. Any questions from the CEPAC panel before we vote? Go ahead, Jason.
This is also a question for Dr. Kimball. So embedded in this question is we have to do something a little tricky here because there's a direct comparison between one of the comparisons in this question. So do you mind just commenting about what you believe the TNF-alpha class effect? Like how can we're not going to have a direct comparison of one of these two comparisons, but can we extrapolate the class effect of TNF-alpha?
What do you mean by just are they all roughly?
Yeah, I mean, we have to make a determination of the...
Are they essentially within the same class relatively equivalent?
Yeah.
So one interesting thing we haven't talked about for certolizumab is the pregnancy aspect, and this is a very unique aspect of this drug that might take the balance a bit, which is that, and they've done very nice work in CVS to demonstrate that certolizumab does not act across the placenta. So IgG is actively transported in the second and third trimester across the placenta. So for most of these antibodies, not necessarily the etanercept, but for most of the antibodies, there's active transport. So that babies born on mothers with adalimumab or infliximab actually have higher drug levels than the moms at birth. Certolizumab pegylated fragment doesn't cross. So there is again, that population of benefit that seems to be somewhat more unique. But to your point, at higher doses of TNF, two phenomena, at high doses of TNF inhibitors, again, it's quadruple the dose of the TNF receptor up to infliximab, you do get incremental benefit, but you don't see that shift to PASI 90 and 100 that you see with the other classes. So there is something about the target that is a little bit different in terms of being able to move people all the way over to the right.
Any other questions, comments before we vote? Okay. So if you haven't voted already, I think there's been a few responses. Go ahead and do that. Now someone needs to tell me what I do next. What do I do next?
Do we have everyone? Oh.
We do. Just do that?
Yep.
Okay, so 2 yes and 9 no. Okay, so the evidence is inadequate to demonstrate superiority for certolizumab. Okay. Okay, so now we're going to turn to the IL-23 inhibitors. And so here we have the first question around, is the evidence adequate to demonstrate that the net health benefit of guselkumab is superior to that provided by all subcutaneous TNF inhibitors? And so here we're now including certolizumab along with adalimumab and etanercept. And Rainer and Feluccio, can you remind us of what the clinical evidence is on those comparisons, direct and indirect?
So we have two head-to-head trials comparing guselkumab and adalimumab, and guselkumab was superior to adalimumab on all the major outcomes, passive 50, 75, 90, and 100, and on IgA, PGA response and DLQI response. Also, an indirect comparison, guselkumab was significantly better than etanercept and certolizumab.
Any questions on that or comments? Okay. People feel ready to vote? Okay. So let's go through the voting. Waiting for one more response. Here we go. Hit it again?
Yep.
Okay, good. So here we have 10 yes and 1 no. So as a rookie at this moderation thing, I've been reminded that I should have asked you with the first question that there were 2 yes votes for certolizumab, and I should have asked if those who voted yes wanted to say anything about why they did so. It's fine if you don't. So similarly here, the one person who voted no for guselkumab, if there are any comments you'd like to make about why that was? Ed, is that you? Okay.
I had trouble with this one. I could have gone either way. I always find myself looking for a reason to find a difference.
Yeah.
Okay. But I'm just the evidence is underwhelming.
Okay.
No.
Okay. Okay. So, Dr. Kimball or Leah, I don't know if you, with either of these 2 votes, if you feel surprised by them, if you've got other things to add, we're happy to take your input as well. No? Okay. Okay, so turning now to risankizumab. Again, similarly worded question. Is the evidence adequate to demonstrate that the net health benefit of risankizumab is superior to that provided by all 3 of the subcutaneous TNF inhibitors? And so Rainer and Feluccio, again, will have you remind us of what the evidence says. In this case, because we've had some questions raised already about the nature of the available data, published, presented, confidential, etc. If you can remind the panel of the nature of the data we have available as well.
We do not have any published data at this point on risankizumab, but we have 2 head-to-head trials presented in conference abstracts comparing risankizumab to ustekinumab, and risankizumab was superior to ustekinumab on all major outcomes. On the NMA for indirect comparison, it was also superior to all the TNF alpha inhibitors.
Okay. Go ahead, Rob.
Just a comment. This was, based on the discussion we had earlier about the nature of this literature and its exposure to peer review and to public review. I would just say that the threshold for getting literature presented at conferences and abstracts is just so far much lower than that to get into peer reviewed literature that it's hard for me say that this is adequate evidence.
So, Dr. Kimball, do you want to comment on that, given that you're certainly at the conferences where these things are presented and part of those presentations?
I sort of feel like there are a couple different ways to manage this. The phase 2 data is very compelling. The conference abstracts, again, I think are subject to a lot of public scrutiny, if not peer review. Certainly, so either if you think the data is inadequate, then I think you defer the question because you don't have the right analysis to do that question, or you decide that the conference data is acceptable as preliminary and there's
One comment I'd make generally is that, so this is not a situation we always deal with, given that this is still under review, and the approval timeline is kind of much further along than our discussion today. But in other situations where we do have a shorter review timeline or even an approval by the time of the meeting, we may still have a fair amount of unpublished data to work with, and if something was approved on some kind of accelerated pathway, we may also not have FDA documents to look at as well. And so the charge of this effort, this group, as well as our other regional deliberative bodies, is to try to make the best of what we have, recognizing that decision makers will have to make decisions very shortly after approval. So.
And the only thing I would note in follow-up is that this has been a recurring issue through the years. And one of the things that we are not saying is that there is either no evidence or there's evidence that this particular agent doesn't work. It's just saying the evidence is not adequate to demonstrate a net health benefit, which is different. And I think we need to make that distinction. We've made it in many of our reports.
Understood.
I had one thought is, and it is true that this has come up before, but we may want to make a very clear distinction and label this as a preliminary vote because it's not FDA approved yet. And in a sense, we want to make absolutely sure that we're not sending a signal that we would expect the same maturity of the data set for a drug that is before and after FDA approval. There are still issues even after FDA approval in which we may not have everything we want, certainly. But I would encourage you to vote with our making a clear distinction that this vote is being held before FDA approval.
You don't look too comfortable with that idea, Rob.
I think the danger or a misinterpretation from the plaque, to your point, it does say very clearly, is the evidence adequate? Again, the phase 2 data was in the New England Journal, I believe, and so it sends a signal that perhaps we'll have to be first relatively soon when the phase 3 data is publicly available, which probably not.
Jason, you have a comment? Or is your mic just on?
No, I'm just thinking.
I think I would rather go the other way around, so we voted on this based on what we have now, and we may think otherwise later.
Yeah. That's what I was said better than I.
Another possibility, right?
I also would like to I'd like to clarify our vote, because we have used this exact same language in the past to say that the evidence wasn't good. And in this case, it's not enough. So we need some phrasing to adapt to that so that we can get this done. And I don't have any.
So in terms of the two alternatives that Teresa and Rob posed, how does the panel feel about the potential wording around this vote? Is it voting on what's available now, or is it couching it as preliminary based on...
Yeah, we're actually saying...
Oh, you're saying the same thing. Okay.
Yeah. We
All
just
right.
think what's available now may not meet the threshold.
Sure. Okay. All right. Any other questions, comments, concerns before we vote, but 8 of you have already voted. So before the remaining 3 of you vote, Okay, so go ahead and finish off the voting. All right. So 2 yes and 9 no. So
yeah, I was one of the 9 no's, but I'm just going to reflect what's already been said, is that I'm really uncomfortable with this particular wording because what Dr. Kimball says that this is probably a good drug and probably is helpful. I'm just not sure we have enough evidence yet as a panel to vote on this as an advisory. So I think the wording is difficult.
yeah, one of the elements of this, I think, so Dr. Kimball, we just talked about the phase 2 trial that is published. Phase 3 results are actually relatively consistent with the phase 2 data, even though they are not published. And so that maybe is something we should have talked about before we took the votes. We can always revote, right? I don't know how much of that would sway your vote. We can't revote? You don't want to revote?
That was actually mentioned at one point.
Yeah. Okay. Yeah. Okay. We can change votes. It may not change the balance of the votes, but... Okay, so we're sticking with 2 and 9? So of the 2 that voted yes, were you swayed by the conversation around the consistency of the data, Steve?
This was a coin flip. I would say yes for a few reasons. One is the magnitude of the effect was compelling. It wasn't just statistically significant because of sample size. It was really, blew the paradigm forward. And mechanism of action biologically fits in line with the other advantages. And I didn't necessarily think this was, maybe a poor abstract or a second-rate conference. It seems like it was a trial that was well conceived, obviously, to support the development of the new drug, and expecting that follow-up data would be coming. So for all of those reasons, I was yes, but it was close in my mind.
Okay.
It's issues of quality measures.
Jason.
I was the other yes vote. I just want to acknowledge the anxiety and the discomfort I have with my vote, although I'm going to keep it a yes. This is very tricky. I think Rob and I have kind of similar types of academic backgrounds, and it's undeniable that there's all sorts of aspects that are readings, especially in observational data, that have wildly different methodological problems. We never see papers. We don't know if the fellow just ended up with a private practice and lost interest. We don't know if there was something really wrong with it and got peer review. But I'm really sort of listening to Alexa's comments and also reflecting on my own kind of experience as a cardiologist. I think the key issue for me is I thought back to my experience as a cardiologist in 2 ways. One is how often is it true that positive large randomized controlled trials are presented at meetings and then we never see a paper when the paper changes? It does occur sometimes, but it's extremely rare. It's extremely rare, and it's usually related to methodological problems. So, like Steve, I was influenced by the effect estimate. So, if the p-value was almost not significant, and it was something that you change in treat analysis, something like that could change. But usually in large effect estimates, it wouldn't make a difference. But Rob, I think your comments are incredibly thoughtful about this, and I think you mentioned this at the last meeting as well, that we have to sort of have standards as academics, and that's why I'm uncomfortable with it. But as a practice matter, these things don't often change. There's also this issue with the published data in phase 2 and phase 3 being what we're seeing from the conference is similar in magnitude and directionality as the published data. So that's ultimately why I was in yes camp, although we're going to have to talk about this is going to come up in future meetings too, so this methodological is very important for us to deliberate on.
Okay. Claudia.
I just want to mention.
Sorry, Steve.
I found this was a difficult call as well, and the reason I voted no was basically for the same reasons that Jason brought up, in that you never know when you have the preliminary data not peer-reviewed and not published, whether there's another study that will be done whether it'll confirm the study or not. On how often do we see studies that show wildly positive results that you never hear medication again. I know there was one classic drug a few years ago in IBD where that happened.
So, New England CEPAC, you were our first CEPAC, and you continue to be trailblazers in helping us find the crevices that we fall into from time to time. I have a proposal because I am concerned that a 9-no, 2-yes coming out at the same time as the votes on the drugs that have been FDA approved, no matter what we do, may be difficult to distinguish. So I just want to at least propose for you guys to consider either I think we should suppress this vote and just say that we are not going to put out the results of the CEPAC vote on the drug because the evidence is too immature, it's not FDA approval. The other option would be to say this is a preliminary vote in which we are taking the assumption, because all the phase 3 data are in the public domain, we are taking the assumption preliminarily that those data as presented in public are valid. And we are not going to discount it because it is not done through peer review. So I think, to me, we either have to do one or the other, to be honest. We either have to just say we're not going to vote because it's preliminary, or we say we are going to vote, and the big assumption here is it is preliminary. Again, we're assuming that the data we are seeing is trustworthy. It would be different if we didn't have the phase 3s, if we had observational study, other kinds of levels of evidence issue, but here it's a phase 3 study results which are in the public domain, which is not through peer review. So we have a little bit of time. I'd be open to either Dan's comment or Rob as chair, but that would be my proposal, would be for CEPAC to consider one or the other as the way forward.
Something that we'll want to solve now, because this afternoon we'll be talking about a drug that's not yet FDA approved.
I agree with Steve. I'm more comfortable with the first of those suggestions of just deferring the vote. I think one of the important things here is the way we're framing the question. If someone asked me to vote on whether there was adequate evidence that the PASI 75 would be responsive to this agent, I would vote yes. But the net health benefit issue on unpublished data is a real problem because we're only seeing what people want us to see. The harms data aren't oftentimes complete. All sorts of adverse effects could be lying there undiscovered at this point. So I think that's a very difficult call to make, to say, well, just based on preliminary data, we're only seeing what folks want us to see. So I would suggest a deferral.
How does the rest of the panel feel? Jean?
I would like another option. I don't like the option of promising, but the data seems good.
Okay.
So I think we're always in this quandary about what's the future going to bring, and we're always optimistic that the future is going to show that that it is promising. I think we struggle with that decision at every one of these meetings. I don't think we're saying anything negative about the drug. I think what we're saying is we can't be that certain that it's any better than the other alternatives. And I'll betray my feeling about the economic data. I don't think that's all that can come either. And I think that where that leaves us is clinicians will make decisions based upon other factors about the patients rather than not such compelling data and not such compelling financial analysis. And it's really what's best for this patient. This information is useful for clinicians, but I don't think it's useful for policymakers.
Claudio.
I actually think Steve's point is a really important one, and I struggle with this from the perspective of not wanting to fall into a trap of a form versus substance debate, where if we unilaterally always say that it's not published and it's just pre-conference materials, that we're going to not include those. I think that there's a great variation in quality pre-conference ones and ones that bear out eventually and are published, and ones that are bad and they're conference form and that's all that happens to them. So I struggle because I think we want to exclude the evidence just because it was indirect and it was from these conference reports, when that may be the best quality evidence we have for some of the newer drugs. And I think we should have make judgments based on when they're most useful for people. So I was probably the ninth vote, the last one on that week as on highlight.
Difficult vote to make. Okay. Any other comments or preferences? So,
are we voting?
That's a good question. Are we voting on how to describe this? I think that probably makes sense. So, option 1 is to suppress the vote for the record. Steve, you have to remind me of the wording you suggested for option 2.
No, it's we would label it as preliminary. We would put that in some special font and color, and say that the vote reflects an assumption that publicly available data, not yet through peer review, are trustworthy.
I think we were in a similar place with brodalumab in the last go-round, and I don't recall that did that. I don't believe that drug was voted on separately from the rest of the class.
We did not have a value vote on it because we had no price, but I believe we did have an effectiveness vote. We did. As a group, right. So we'll have to do a show of hands since we have no electron.
We go to Steve's second choice if
yes.
we have to revote. Correct.
Right.
Can I sorry, just separate all these things. In option 1, if we end up voting for option 1, does that create a duty to take the same approach in the future rather than the same situation?
No. Okay. It helps inform our decision about what a precedent or guide. It's clear we need to be more specific so that we can do this in a very standardized way. Right now we're kind of ad-libbing, but we will take it as part of the input into what we should do going forward.
And then is that, I also wouldn't want to tie ICER's hands in terms of being proactive and asking questions in kind of ways either.
No, this won't, to be honest with you, this won't tie our hands. I think we need to figure out what you feel in particular is the best way to handle this situation, and we'll take it as input to make a broader policy approach decision going forward.
Claudia.
Jean did recommend the third option, closed voting is promising. I don't know whether that would work into our delivery.
I almost think that's in your second option,
Yes, the concept is, the word promising is one that gives me problems. We even use it, not we say promising, but inclusive in one of our own evidence ratings. But that's one of the harder ones when we pitch it to you to say, is that adequate or not? And you maybe do the Solomon's choice. So I do not think we should have a vote on a different language other than this option of saying it's something about the assumption about the validity of the preliminary data.
I'm comfortable with the way Stephen has worded it.
Option 2. Okay.
Can we repeat option 2 that will be voted on?
Option 2 is assuming that the evidence in the public domain from non-peer-reviewed literature is taken as valid. Do you believe the evidence is adequate to demonstrate ...
So I can read that preface if we revote. But first we need a show of hands on whether you prefer option 1, which is to suppress the vote, or option 2, to revote using the preliminary wording.
I will also add that one of the policy considerations is option 2 may imply a responsibility or duty upon ICER to follow up once the data are peer reviewed. So that's part of what we're going to need to think through. We need to have things hanging out there that are obviously preliminary without some follow-through.
So, all in favor of option 1, suppress the vote. 2 of the 9. Oh, wait a minute. Oh, sorry, I counted 2. I didn't say option 2, but all in favor of option 2. The remaining 9. Okay, so we will revote. And Celia will have to manage the
So I'm
science
not
around
going
that.
to type out the new language, but you all have it in your brains about what it will look like in the report. I'm just going to reset this question. So it should be reopened on everyone's screens. I have 0 responders right now. Now 1.
is there preliminary evidence suggesting or to demonstrate it's pretty strong, but that the net health benefit is superior?
I just want to make sure that the assumption is very clear that we're taking at face value the non-peer reviewed data. I want that to be kind of lockstep with the voting question, if that's all right. But I think we mean the same thing.
All right, so feel free to now re-vote. 7 of you already have 8. How do you know who hasn't voted? Oh, wait, one more. So who's the one more? Suspense is palpable. There we go. Okay. All right, I need to get rid of this response grid. Is that what I do? I don't know what's happening here, Celia.
So one click.
I've done 4.
There we go.
So a complete flip. Now 10 yes and 1 no. I think we had lots of extra time, now we don't. So we've had plenty of discussion about this one. Okay, so the final effectiveness vote is on tildrakizumab, the last IL-23. Same wording. Evidence to demonstrate that the net health benefit of tildrakizumab is superior to that provided by all 3 of the subcutaneous TNF inhibitors. And once more, Reiner and Feluccio, can you remind us and point out where in the evidence packets the data are on this comparison or these comparisons?
We have one head-to-head trial comparing tildrakizumab to etanercept, and tildrakizumab was found to be superior to etanercept on all PASI outcomes, but not significantly different from etanercept on PGA response and DLQI response. On indirect comparison, we found that tildrakizumab was not significantly different from adalimumab and certolizumab pegol.
Any questions or comments on that evidence? Dr. Kimball, any comments on Tildra versus the other IL-23s in your mind? Or?
Just that and I would distinguish the IL-23 12 inhibitors that are used to came back from the T19, what we're typically calling for IL-23. There does seem to be more variability in that class in terms of their relative effectiveness.
Okay. So no other questions about the data from the panel? No? Okay. So we should go ahead and vote. One more. There we go. Okay, so unanimous no for tildrakizumab. Okay, so now we're going to switch things up a bit as we do, where we talk about other benefits as well as contextual considerations. So the first slide discusses other benefits. And so in comparison to the universal comparator for our evaluation, non-targeted therapy, we're thinking about all 4 of the newer agents now. And in your mind, do these newer treatments offer one or more of the following potential other benefits? So the list is here. Offers reduced complexity that will significantly improve patient outcomes, will reduce important health disparities across racial, ethnic, gender, socioeconomic, or regional categories, will reduce caregiver and or family burden, is a novel mechanism of action or approach. So this is something that often comes up when it's not quite the case here. We talk about rare disease. We may have a new mechanism of action that significantly changes clinical practice. Will have a significant impact on improving return to work or overall productivity, and we heard that there's a small amount of data on productivity in these trials, but not a ton. Offers other important benefits or disadvantages, in fact, in your mind. So these could be any number of things that you might think about. And so you're able to vote on, this is obviously a multiple option question. You can vote on any of them and all of them. Any comments or concerns first about the categories or how you should be viewing the newer treatments? Claudia?
Can you clarify, is a novel mechanism of action again or approach?
So it could be a new class of agent. It could be a new mechanism of action within a class. So we, in terms of what we have in front of us, in terms of the 4 new agents, 3 of them are in the selective IL-23 inhibitor, or P19 is what you refer to them as, class. So that is a new class of agent.
Yeah, when you first said that, you said that unlike other illnesses, there weren't new mechanisms.
So I was probably using the wrong example. So it is the case that 3 of these 4 agents represent a new mechanism of action or a new class of therapy. But you need to weigh the relative importance of that in your mind, given the data on the performance of them. Leah, I don't know if you want to make any comments about the categories as they're listed here.
Offers reduced complexity, I would say, absolutely. Lab monitoring reductions, again, these patients, when they're in a stable place, are about these patients to take care of in the practice. It's a delightful change from 15 years ago. Unfortunately, I don't think we quite have the leverage to figure out how it will come across these categories yet. I think that's the key work of the committee in some ways, is to figure out how the economic balance to make these drugs more accessible both here and maybe elsewhere. Reducing caregiver and family burden. Very clear when we look at quality of life impact on family members for patients with psoriasis, that there's extreme benefits to the patients being better, to the entire family and their environment. Novel mechanism, as I said, I think we haven't talked about safety data very much, but there is some interesting data about the safety as we continue to narrow and change where we're affecting the pathway. TNF obviously has a lot of pathways. We use in some ways the P19s do seem to have a mirror field effect. So I think still some to come on that issue, but certainly it is a novel mechanism that has some interesting opportunities. Work productivity typically is presenteeism that improves rather than absenteeism for psoriasis patients, but that's been clearly demonstrated in multiple studies when you improve the disease, even if it's not drug specific. And again, I think we talked about a little about psoriatic arthritis, potential for other comorbidities, but the well-being of patients clearly is
No, I don't have anything to add to what Dr. Kimball said. I think, just again, having the plethora of options and all the tools kind of from a patient perspective is what they're after.
Great. Okay. If we're ready to vote, most of you have already done so, we can finish that off. Okay. So for these categories, 10 of the 11 voting for reduced complexity, 0 for disparities, 7 for reductions in caregiver family burden, 8 for novel mechanism of action, 8 for productivity improvements, and 6 for other important benefits or disadvantages. Does anyone want to vocalize some of those other important benefits or disadvantages? Stephanie.
For me, the important other benefit was the potential benefit on mental wellness of patients, and so that's what I was thinking of when I answered this question.
So correlated with better effectiveness of the drugs, improvements in Claudia?
I also think we have to think about the cost factor in regards to it as a potential disadvantage, and that's why I voted for that question.
Important, okay. Anybody else? All right, let's move on to contextual considerations then. Okay, we have a list here as well. So are any of these following important in assessing the long-term value for money for the newer targeted immunomodulators? So here we're long-term value for money, as a reminder, includes your views on the clinical evidence, also the data on the long-term cost effectiveness, as well as the other benefits we just talked about. So are these newer products intended for the care of individuals with a condition of high severity in terms of impact on quality and or length of life? Intended for the care of individuals with a condition that has a high lifetime burden of illness? Are they the first to offer any improvement for patients? So that's Brian, that's the analog that I should have been making here on what happens in rare disease oftentimes. Compared to non-targeted therapies, is there significant uncertainty about the long-term risk of serious side effects? Is there also significant uncertainty about the magnitude or the durability of benefits over the long term with these? And are there, again, other important contextual considerations that you'd like to consider? And again, I'll ask our experts to offer their thoughts on these categories if they'd like to.
I hope that you've heard from both me and the patient that spoke to you in 2016 about the really severity of psoriasis on a person's life and the impact, as Dr. Kimball mentioned, on not just the person living with the disease, but family members as well. And I think we've shared in the past the statistic that 88% of people living with someone who has moderate to severe psoriasis report those same levels of anxiety, frustration, and helplessness. So certainly, with regard to the first 2 points in particular.
I struggled with, I'm not sure I'm interpreting quite correctly how to work with D and E, but I'll tell you my opinion about long-term safety and what is known and not known. So some of these drugs have been available and have been used in clinical practice for 15 years, and there's patients who've been on them. I've treated for 10. So I think we have, for some of the classes, really well-characterized risk profiles, and that in general, long-term treatment seems very appropriate risk-benefit decisions for those patients. Some of them are very new, but I will say that P19 inhibitors do affect the same pathway in IL-23 as ustekinumab, about which we now have really pretty robust longitudinal data in the sort of 8 to 9 year time frame. And thus, far, that drug certainly doesn't seem to have any additional risks, and may have, even as you've already heard today, a better safety profile in some ways than alpha inhibition. So I don't see those in contrast to, say, cyclosporine and methotrexate, which would be the non-classic, non-targeted therapies. Certainly, the short and medium-term profiles appear to be safer. And again, the data would suggest the long-term will probably be that way as well. But we don't have to yet.
Okay.
So I had word that you can only select 2. Is that correct for everyone? So I'm going to re-poll the question, and I'm going to add the ability to have more questions, select more answers. So before everyone votes.
While Celia does this, any questions from the panel on these categories that Dr. Kimball or Leah have not answered for you? No?
So I've re-polled the question, so everyone needs to answer.
Looks like one more response. Oh, there we go. Okay, so condition of high severity, 10 voted that was the case. High lifetime burden of illness, 8. First to offer any improvement for patients, 1. Significant uncertainty about long-term risks, 7. Significant uncertainty about long-term benefits, 7. And other important considerations, 2. Anyone want to talk about the other considerations that they thought were relevant? Jean.
I was going to echo Claudia's comment on the last question, but my continued concern about, it's the equivalent of rate inflation. We have a whole group of medications for this condition that are all kind of escalating in cost, clustering around a certain cost or quality that is going to be a long-term burden on the patients, on the employers, on the payers, on government, and I'm just thinking about the late great Reinhardt and say, what's the prices? I'll leave out the last word.
Okay. Steve.
How was the other 2 with other considerations? And it was the point I made earlier about the generalizability of the study population to patients that will be treated in the real world, and their comorbidities, and ability to achieve a higher quality.
Given that profile.
They're unable to get quality of life improvement to the extent of the patients in the trials that would impact the ICERs.
Okay. All right. So why don't we move on to? I do want to have. Oh, go ahead.
Just really quickly, I think that this is a place where I look to put some context around the PASI score not being the only indicator. So when you look at someone with an achievement of 75, but it could be in the right places that gives them a more productive life, allows them more social interaction, that this is something we can consider, that it's not just the score, but the context of how the score impacts quality of life, productivity, and social engagement.
Okay. So value votes, we only have 2 because only 2 of the 4 agents have a price at this point. So the first question is about guselkumab. So given the available evidence on comparative clinical effectiveness and incremental cost effectiveness, and considering those other benefits and contextual considerations we just discussed, what's the long-term value for money of guselkumab compared with non-targeted therapy? And Dave, can you remind the panel of what the results were for your cost-effectiveness evaluation?
In the base case for guselkumab versus non-targeted, it was just above 150,000 volleys, 160 something. A fair amount of uncertainty around that estimate. We don't actually know what the net price in the marketplace is exactly. That's about it.
Other comments, questions from the panel? Brian.
I think I've struggled with this on other panels, is that this is compared to to non-biologics. So we're compared to non-targeted therapy. That's not how most of these patients are going to be seen, is it? That the other targeted therapies have been around for a long time. So if they've got moderate to severe disease, the new drug isn't going to be compared to non-targeted therapy. So it's hard for me to make a value judgment. We're very
But keep in mind that, as Dr. Kimball noted, this is a sort of, in the perfect world, without some insurance challenges, this is a suite of agents to choose from to treat patients who haven't responded to systemic or non-targeted therapy, other non-targeted therapy. And so, and given that most of our clinical evidence is with that comparator, that's how we've had to approach it. So you have the value worksheets are available to the panel, right? Yeah, so you can take a look at.
Just make one quick point.
Sure.
Just one quick point. Dave is very correct in that there is uncertainty around what the market price will be with rebates from the list price. But for the purposes of your vote, you should assume that that is what you're voting on, that price. You don't have to, in a sense, worry about that piece of uncertainty in the model in your own voting. So, and it's on page 10 of the evidence summary. It's the base case cost per call was $161,000.
Slide 50. I'm going to need help going back to slide 50. Get my technical advisor up here.
We may have to re-pull the.
Oh yeah, so you can look on page 13 of your packets. Slide 50 is at the top right. Guselkumab is the brownish color. It's kind of as Dave described it, it's in the mix with the IL-17 inhibitors. So the brown is next to the blue and the green. So it's near ixekizumab, and is that infliximab?
Yeah, I mean, rather than worrying about which exact line it is, I think a good way to think about it is it's not zero, like some of the drugs. Right. It's not as high as those top two, infliximab and Verdina, but it's in the mix with those other ones. But this analysis is comparing everything to everything else. So this is the analysis Brian was talking more about. This isn't looking at solely versus non-target. So it's a little tricky. From a method standpoint, from a cost-effective standpoint, this is fairly.
So people are feeling ready to vote. I'm going to ask for that to happen because I do want to leave at least a few minutes for some reflection at the end. We're getting close to the end here. So low, intermediate, or high would be your choices. Okay, so we've got 2 low, 8 intermediate, and 1 high. Okay. Again, apologies, but probably not some time to talk about who voted where right now. So let's go to the other value vote, which is certolizumab compared to non-targeted therapy. And Dave, can you remind folks of the results there?
Yeah, I can remember exactly where it is, but
I think it was 188. Was that the base case result?
we're above 150 when we're looking at this.
188.
188.
188.
That was with the, assuming half at the lower dose, half at the higher dose.
And then when we looked at just the lower dose, that was approximately 130,000 per call with just looking at the lower dose. So if you consider a weighted population based on the average body weight of the trials, when you're about half taking lower, half taking higher, you're at about 190,000 per call. Just the lower dose is closer to 130,000 per call.
And the lower dose did not have as good efficacy, if I remember
slightly lower.
Not quite as good.
Is the most influential factor in the model the actual cost of that difference? It's because the different doses cost a different amount.
Yeah, in general, yeah, those are most influential.
Gene. Certolizumab.
Just processing some data. So especially for diagnostic non-targeted therapies, right? In this case, methotrexate category. In previous categories would be an X, right, for the patient. Cyclosporin was categorized as a category C, but is absolutely associated with low birth weight and some other issues as well, not related to birth defects. But that compared to essentially no drug exposure at all would be a substantial difference. And of course, the other systemics would be psoriasis, which is also retinoids, also category X. So there are really no good choices in the non-targeted therapy market.
All right, why don't we go ahead and finish off our voting? Two more to go. One more. Still one more. What was that? Oh. Gentle reminder, okay. Now we've got 11. There we go. All right, 7 low, 4 intermediate, 0 high.